Hi, good evening, everybody. Welcome back to our webinar, another one. And this time we have Dr. Aslannif Roslan, and he's currently actually in Mayo. What time is it in Mayo now, Aslan?
It's 9 p.m. Sorry, it's 7 a.m.
Well, thank you so much for making this time,
No
waking up
problem.
early and giving us this webinar.
No problem.
I've been following your webinars on Beyond Houseman. You've been
Yep.
very active there, and then a lot of echoes. So if you are very interested in heart failure and echoes, please do watch his webinars. That is very, very interesting. So without further ado, maybe we'll get Dr. Roslan to start talk on cardiac emergency.
All right. So thank you very much, Dr. Betty,
Yeah, just call me Becky will do, please.
for inviting me for giving this talk and cardiovascular emergencies. Good evening there in Malaysia. So today I'm going to talk about cardiovascular emergencies. We will touch a little bit on PCI and also on electrocardiogram. So we will talk a little bit about ischemic cascade. So I think this is very important, especially if you are an emergency doctor physician, because we wanted to know what is the first thing that have changes once you develop acute coronary syndrome. So at first you have the metabolic effect, so the release of lactate. Obviously you cannot detect that when you are in emergency department. After that, you can have regional diastolic dysfunction. As of yet, we haven't had study yet in terms of regional diastolic dysfunction for acute coronary syndrome. And the one that is the most important at the moment is regional impairment of contractility. So if let's say you suspect someone of having acute coronary syndrome and you see that the electrocardiogram is not really diagnostic, and you are in two minds whether you wanted to diagnose acute coronary syndrome or not, regional impairment of contractility, regional wall motion abnormalities is really important. So if you see someone with, for example, hypokinesia in the inferior wall of the left ventricle, so that is very, very likely there's some acute coronary syndrome going on. As you can see, the ECG changes happen quite later than the impairment in contractility. So that's why that is very important. In terms of recovery of left ventricular function in the era of primary angioplasty, I think this has happened more frequently. I think a majority of people can have complete recovery if, let's say, we diagnose myocardial infarction quickly. So that's why it's very important for me. The most important thing as a new doctors or even as a senior doctors is to know how to diagnose acute ST elevation myocardial infarction in ECG. Never miss the diagnosis. Even though regional wall motion abnormalities is very important for diagnosis of acute coronary syndrome, it is important to remember that there is other reason that you might have regional wall motion abnormalities. So there can be abnormalities of the septal wall of the left ventricle because of left bundle branch block, pressure and volume overload. So it's important to know the different way the septal can move. If you have Wolff Parkinson White, there is also possible for you to have regional wall motion abnormalities and even myocarditis. So one thing that I wanted to remind in terms of cardiovascular emergencies, it is impossible to differentiate just from either electrocardiogram or echocardiogram alone myocarditis and acute coronary syndrome. So every time you suspect someone of having myocarditis, make sure that you roll out acute coronary syndrome as well. It can mimic the regional wall motion in acute coronary syndrome, and it can even mimic ECG. The other cardiovascular emergencies that I list here is something called Takotsubo syndrome. So for those of you who are not familiar with Takotsubo syndrome, this is also known as broken heart syndrome. So, you know, in a typical presentation of this patient is elderly lady with acute stress, and suddenly they develop what look like acute coronary syndrome, but the coronaries is normal. And when you do echocardiogram, you can see an apical ballooning. They call it Takotsubo because this is actually the name for the trap that the Japanese used to catch octopus. So it looks like this when you do left ventricular ventriculogram for Takotsubo cardiomyopathies.
Sorry, may I stop you here and ask you,
Sure.
though it is Why is Takotsubo acute emergency? Usually they present with heart failure, is it?
They present usually is present exactly the same as acute coronary syndrome, but the problem is they can present like an ST elevation myocardial infarction. So it might be impossible to differentiate the two. So one of the way
I
you
see.
can possible to differentiate is by using
An
echocardiogram where you see apical ballooning. But even then, it is still not 100% differentiable from acute anterior myocardial infarction. Even though these people can recover from Takotsubo, it is one of the better cardiomyopathies. It does can cause death in very rare situation. So that's why I put it as part of
Yes.
cardiovascular emergencies. Um, so I just so what is the predictor in terms of post myocardial infarction in terms of prognosis? So I just touched down that ejection fraction is very important. So for those of you who are not familiar with ejection fraction, so ejection fraction means that how strong your heart is contracting. So normal value is about 52% in terms of upper limit for male and 54% for female. So anything below then we say reduced ejection fraction. So that is one of the indicator of patient developing heart failure. Now, one of the important thing when we learn about cardiovascular emergencies is number one, if let's say you are in emergency department and you look at electrocardiogram and someone come for acute coronary syndrome, and if you are in a PCI able center, when do you want to go for urgent PCI? When you want to pick up the call and call the cardiologist and send the patient for cath lab. So ST elevation myocardial infarction. So this is number one. Always send this patient for primary PCI. If you are not in a center able to do primary PCI, then you thrombolize the patient. So that's why it's very important to recognize someone that has failed thrombolysis. So if you are in a center that cannot do primary PCI and you give the patient thrombolysis, the ST elevation does not resolve or the chest pain continue. So that is another indicator. Another one that is important is chest pain with worrying ECG changes. Remember that ST elevation, it is not the only reason for you to do urgent PCI. What do I mean by worrying ECG changes? I always say this during my talk that ECG is a very cheap modality. So it's just an ink and a paper. So whenever you are worried, whenever you are not sure, repeat the ECG. So any evolving changes is a worrying one. And there is a eponymous name for a certain syndrome, such as Wellens syndrome that we see often, and De Winter syndrome of the ECG that is almost the same as ST elevation myocardial infarction that we need to recognize. And I will show you a little bit later. Another ECG that is important to recognize is someone with widespread ST depression and ST elevation in AVR. That something that suggests that the patient having widespread ischemia. So this can be either proximal left anterior descending or even a severe vessel disease that warrant urgent PCI. And another one is someone with persistent angina. So if you see someone with angina and you give them medication and they're still having chest pain, so that is an indication for urgent angioplasty. I like to go through cases. So our first case is a 55 years old woman with chest pain. So ECG was done 2 hours apart. Okay, so this is the first ECG here. One of the most important thing is to recognize the ECG. Now, if you look at the first ECG here, if let's say you look once without looking into detail, you might say that this ECG is normal. So I just wanted to show you what happened when we repeat the ECG 2 hours apart.
inferior
So that's
lead,
the,
is it?
sorry?
Inferior leads.
Yes, exactly. So there's something wrong with the inferior leads. So you can see that there is a little bit of ST elevation in loop 2 and AVF. So even with this ECG, you should have diagnosed that the patient have inferior ST elevation
But
myocardial
actually, the
infarction.
first glance, I thought it was normal, to be honest.
Exactly. Yep. So if you see, if you repeat the ECG, then you can see that the ST elevation has gone up markedly in lead, especially in lead 3 and actually in lead AVF. So you wouldn't miss the finding that you do after you repeat the ECG here. So it's always important to repeat ECG, otherwise you can miss stuff. Another thing that I wanted to just show you a tip, okay? If you have inferior ST elevation myocardial infarction, the first thing that change is actually your AVL. So the first thing that happened is either ST depression and or T inversion in lead AVL. Okay, so whenever someone come to you with chest pain, if let's say the ECG looks completely normal, but the AVL have ST depression or T inversion, always beware, because that is the first presentation for inferior ST elevation myocardial infarction. So repeat the ECG. They have a study done that almost more than 99% of patients with inferior MI start with ST depression and T inversion in lead AVL. So that's very important. Another very important thing to see, if you look at lead V2 and V3 here at the beginning of this ECG, you can see that there is a little bit of ST depression in lead V2 and V3. So this is very suspicious, because in lead V2 and V3, in normal people, the ST should be slightly or up or isoelectric. If you see even a little bit of ST depression in lead V2 and V3, you can see here a preserved R wave. So that is abnormal. Okay, that is posterior ST elevation myocardial infarction. So in fact, this patient have inferior posterior ST elevation myocardial infarction, and you can see a more marked change in lead V2, V3 after 2 hours, and you can see that horizontal ST depression with preserved R wave. So why is this important? Again, someone can come with isolated posterior ST elevation myocardial infarction. So they don't have these 2, 3 AVF, but they only have changes in V2 and V3. So you might mistaken this as ischemia. So that is wrong. Okay, this is a posterior ST elevation myocardial infarction. Remember that ischemia does not localize, only ST elevation localized. Okay, so you cannot, looking at ECG, you cannot say whether this is a posterior, anterior, or inferior ischemia. So this is an example of someone with inferior posterior ST elevation myocardial infarction. So this is the kind of patient that need to go for primary PCI or thrombolysis. So you can see the changes there.
Quite young, huh, for
Now,
a 55-year-old to get MI.
yes, we can, I've seen youngest, I'm sure you have seen young patient with
Yes,
ST elevation MI. I see 22 years old with ST elevation myocardial
a
infarction.
lady. I've never
No,
seen a lady who's a
not
man.
a lady,
Yes.
not a lady, a boy. Yeah, sorry, a man. So, so I just wanted to show you an example of an echocardiogram where you can see a regional wall motion abnormalities, in which you might be suspicious. So in this kind of patient, so this is what we call an apical two-chamber view. So this on top here is your left ventricle. Okay, so from here to here, if your left anterior descending artery distribution, you can see that your basal inferior wall especially, so there is hypokinesia. So whenever you see someone that you suspect of acute coronary syndrome and you see hypokinesia, beware that this might be an indicator of acute coronary syndrome. So this is a pace that is supplied by the right coronary artery. So that exact patient, with not significant ECG changes, we bring to cath lab just based on the echocardiogram. So that is actually an initial changes of acute inferior MI, and lo and behold, when you do the angiogram, you can see that in the right coronary artery, there's actually total 100% occlusion in the proximal part of the right coronary artery. And this is when we open it. Okay, right coronary artery has opened. And this is one of the something that very the one that make us, I think, both me and Dr. Betty do cardiologists, because we can have this instant
Visual
gratification.
satisfaction.
Yes, of really saving patient life. I think primary PCI is one of the
Yes.
most important thing and most life-saving treatment that we have for myocardial infarction, and we can see is in front of our eyes the patient getting better. So when patients have myocardial infarction, and the problem is they can have complication for myocardial infarction, and then can present in your emergency department as cardiovascular emergencies. So you have to recognize all these mechanical complications. So let's see this question. So I will answer the question. So what is the most common mechanical complication of myocardial infarction? There is legions of myocardial infarction complication. So you can have papillary muscle rupture, okay, and that is basically a trip to the operating theater. Okay, if you don't go to operating theater, you'll die. Ventricular septal rupture, that's another one that is very controversial. This can happen. Okay, so whenever you have someone with heart attack and you hear a murmur in the heart, always look for the source of murmur. The murmur is never innocent. Okay, so the papillary muscle rupture can cause pansystolic murmur. Ventricular septal rupture can also cause pansystolic murmur. Free wall rupture, There's another one. Okay, so you have a rupture in the free wall. So this is almost 100% fatal. I have seen cases that is not fatal, where we go straight away to surgery, but most of the time, a patient have free wall rupture, they will die before they come to hospital. There's also another thing that is called intramyocardial dissecting hematoma. This is one complication that I wanted to let you aware today. Left ventricular outflow tract obstruction post myocardial infarction, left ventricular aneurysm, left ventricular pseudoaneurysm. So this is the myriad of complication that you can have from myocardial infarction, but the most common complication is left ventricular free wall rupture. So those of you who do emergency department or do internal medicine will ask me, oh, you say this is most common, how come I never see it? So the reason you never see it is because the patient die before they come to hospital. Which of the following is the poor prognostic factors following myocardial infarction? So the answer for this question is actually all. So if you have a poor ejection fraction, if you have high wall motion score index, meaning that you have a lot of regional wall motion abnormalities, if you have diastolic dysfunction, all of those are poor prognostic factor following myocardial infarction. So which of the following is false? So this is talking about complication of myocardial infarction. Okay, so when we have ventricular septal rupture because of myocardial infarction, we can have VSD because of anterior myocardial infarction. So this is usually simple and located at the apex. What do I mean simple? It means that the defect is just a straight defect between the left ventricle and right ventricle. If you have inferior MI, sometimes the defect can be complex, meaning that the defect can take a serpiginous route inside the septal wall. So the defect might start in the inferior wall, but it go out on the left or the right ventricle at the apical wall. So that can be complex ventricular septal defect. Okay, so that is also true. What about intra-aortic balloon pump? So this is something that maybe those who are cardiologists or cardiology training know. So IABP is sort of a mechanical support that we give in the setting of shock. So if they say we were doing procedure and someone with myocardial infarction and their blood pressure persistently low, some of us will put an intra-aortic balloon pump to help the diastolic filling of the coronary arteries and to reduce the afterload. However, IABP is actually contraindicated in the setting of dynamic left ventricular outflow tract obstruction. So it will make this LVOT obstruction worse. So never put IABP in someone with dynamic LVOT obstruction. I will show you the example later. What about this anterolateral papillary muscle rupture is more common than posteromedial papillary muscle rupture. So this is the false one. The most common rupture is posteromedial papillary muscle. So I just wanted to tell you that in the left ventricle, we have two papillary muscle. We have anterolateral and posteromedial papillary muscle. Anterolateral papillary muscle is supplied by two coronary arteries, but posteromedial papillary muscle is supplied only by one coronary artery. So therefore, posteromedial is more easily ruptured than anterolateral papillary muscle. And the last one is true. There is a difference between pseudoaneurysm and aneurysm that I will explain to you a little bit later. So this is, I think, one of the most important picture that you need to remember. So you need to remember the name of segmental left ventricular wall, and you need to remember what kind of coronary artery supply that particular wall. And in terms of how to name a particular wall, okay, one tips that I want to give you is, number one, just divide the area that you see into three segments. Is it basal segment? Is it mid segment? Or is it apical segment? So any wall that you see, it is either basal, mid, or apical. Okay, so that's one tip. The other tip is always, whenever you see a right ventricle in the same picture as left ventricle, the wall that is in between is a septal wall. Okay, so I give you an example. So this is basal inferior septal wall. This is mid inferior septal wall. This is apical septal wall. Okay, again, this is basal inferior wall. This is mid inferior wall. Okay, that's how you're going to remember your wall. It's not easy. It takes me a long time to remember, but you need to practice every time you see echocardiogram and try to ask yourself which wall that is involved. Okay, and in terms of coronary distribution, one advice that I can give you is Just think about two distribution, left anterior descending and right coronary artery, and just remember them. For example, from here to here is LAD, from here to here is LAD, and from here to here an LAD. The rest is considered to be right coronary artery. So we have a 56 years old man that come with 6 hours duration of chest pain. ECG and coronary angiogram is as follows, right? So this is the electrocardiogram. Okay, this is a real case. So look at the electrocardiogram here. So if you look at lead 1, 2, 3, lead AVR, AVL, and AVF, so what do we see here? We see something, ST depression in lead 2, 3, and AVF. So does this mean that the patient have ischemia in inferior wall? No. Remember, ischemia does not localize. Whenever you see ST depression, you can say ischemia, but you cannot say where does the ischemia originate. Remember, when you do exercise stress test, you always see ST depression in V2, 3, AVF, V4, V5, V6. But when you do coronary angiogram, the lesion can be anywhere. It can be LAD, circumflex, or right coronary artery. So this is suggestive of ischemia, but more importantly, if you look at it V2, V3, V4, okay, so you can see that this is a tall T wave. So one of the differential diagnosis of tall T wave that is tented is hyperkalemia. Okay, what do I mean by tented? Meaning that the T wave is very sharp, so that if you were to sit on the T wave, it might puncture your buttock. Okay, so that is tall tented T wave of hyperkalemia. Okay, now, but this is not. Another thing, hyperkalemia, is that the T wave is thin. Okay, this is a bit different. The T wave is a bit more wide. Okay, and more importantly, if you look at it V3 and V4 and V5, you can see an ST depression followed by giant T wave. ST depression followed by giant T wave. This is what we call a De Winter's T wave. Okay, De Winter's T wave. So this is actually equivalent to anterior ST elevation myocardial infarction. So this is a real case that I diagnosed as De Winter's. So this is the same as ST elevation myocardial infarction. So please remember this ECG. So if you look at the ECG,
De Winter's?
I think that is the name of the person that discovered it. Okay, there's
But
two.
is it usually 6 hours of chest pain? The ST elevation would have.
So that's the
more typical, right?
Exactly. So that is the difference between De Winter's on ST elevation MI. In ST elevation MI, you can see the progression of the ECG. In De Winter's, it tends to stay the same.
I see. I see.
Yeah. So this is something special. De Winter's T wave. And this is actually the angiogram. So as you obviously know, that you can see that the LAD is actually occluded proximally.
So the presentation is still chest pain.
Yeah.
The angiogram is still a complete occlusion of the artery.
Yes.
So everything is actually an ST elevation MI.
Exactly.
It's
exactly.
Just that the T wave is hyperacute looking.
Yes, and
even though it is
preceded by
later.
it is preceded by ST depression. That's very important.
Oh, I see. Okay, so
it must be preceded by ST depression.
This is interesting.
Yeah. So you can see that. So I mean, basically, we open the. I mean, whenever you do angiogram, this is always of interest to cardiologists, but not so much for those who are diagnosing. I mean, that's why the diagnosing is the important part. I mean, the treatment we can do, but we need to diagnose and recognize the ECG. All right. So we did an echo a few days later, and you see this kind of heart. Okay. So what is happening here? Someone that is diagnosed as ST elevation myocardial infarction. Okay. So for those of you who are not familiar, so this is the apical 4-chamber view. So that's your heart there. So that's the left atrium, right atrium, left ventricle, and right ventricle. Okay, so what is happening? You can see a cavity here that is big. Okay, so this is a complication of myocardial infarction. So this patient have a wall rupture. So this is actually a free wall rupture. But luckily for this patient, the rupture is actually contained by the pericardial cavity. Okay, so this is actually a pseudoaneurysm. Yeah, so the complication of myocardial infarction or cardiovascular that you need to know. So what is the difference between pseudoaneurysm and aneurysm? It is very easy in terms of the definition. So pseudoaneurysm meaning that the integrity of the wall is already damaged. meaning that you do not have all the three layers, the endocardium, the mid myocardium, and the epicardial wall of the heart. So that is pseudoaneurysm. In aneurysm, all the three layers are still there, only it becomes thin. So for example, in this one, you can see the disruption of the layer, and this is the cavity here. So in terms of diagnosing it, okay, what is the difference? The difference is in pseudoaneurysm, the neck is narrow. In aneurysm, the neck is wide. In pseudoaneurysm, you can see the to and fro flow of the heart. You can see that the blood flow into the cavity and then come back in, flow into the cavity and come back in. Okay, that is pseudoaneurysm. Aneurysm won't behave that way. So how do you manage this? We manage this with trip to the operating theater. So this is a left ventricular pseudoaneurysm. They have to go to operating theater to take out that pseudoaneurysm.
Now let's go back to that thing again. So now, of course, this is a day after your procedure, which is your primary CA. Now to go for an operation, with the stent on board, with the dual antiplatelet on board.
I think I think that is the thing that is, it's going to be a nightmare. I mean, it's easier said. It's easier said during a teaching or theoretically speaking than done. You know, but but we have to do it. So this also happens sometimes with patients with ventricular septal rupture as well. You do the PCI, they develop this VSR after the PCI. So and then after that they become hemodynamically unstable. Then it becomes a nightmare. So we have to go in, but and the surgeon will have a difficult time dealing with this kind of situation.
The other question is this more common pertaining to your de-winters, or is it because of the duration of the time that
it is because of the duration. It's nothing to do. I mean, it is just a complication of myocardial infarction. It's not specific for the de-winters. You know, any kind of myocardial infarction can cause this, especially if you treat it late.
So I think we need to emphasize to all out there that duration window period that is best is within 3 hours, because in any myocardial infarction, earlier the better, because want to actually save myocardium and then
you're right.
Reduce the risk of any of these complications that Dr. Aslan is going to show us more.
Yep, exactly. So I've already talked to you about what is LV pseudoaneurysm, so we don't need to belabor the point. So this is an interesting. So if you were to put your echo Doppler and you see this to and fro, so this is only one thing can cause this, okay, pseudoaneurysm. So if you have an exam, so for example, at echo exam, if they give this picture and they ask you for a spot diagnosis, so this is basically a diagnosis of pseudoaneurysm.
This is across the.
Across the defect. So if you put
the defect, right?
Yep, exactly. So if you put the Doppler there, so you can see a to and fro Doppler profile on your profile, like so. So you can see that.
I see. Okay.
Yep. So that's very special. So a 60 years old heavy smoker come with profuse sweating and chest pain. So look at the following ECG. All right. So this is the initial ECG. Okay. So when the patient have patient come to the emergency department. Okay. Now at first when he came, the chest pain has got better. Okay. And then suddenly in the emergency department he developed again chest pain. So initially when the chest pain is better, this is the electrocardiogram. Now when the chest pain come back again, so this is the time when they have chest pain, when the patient is in the emergency department. However, when the patient does not have chest pain, you see this kind of ECG. Okay, so would you be reassured by this kind of presentation, even though the patient does not have chest pain? If we're looking at this type of ECG, so obviously not. Okay, so you would ask yourself, why when the patient having chest pain, the ECG looks fairly normal. When the patient doesn't have chest pain, you can see the biphasic T wave in lead V2 and very deep T inversion at lead V3. Okay, what is going on here? So the first case just now, I actually introduced you a term called de-winters. So now I wanted to show you another type of ECG that is what we call a Wellens. Okay, Wellens ECG. So what is Wellens ECG? So someone with a Wellens ECG, what they have is they have a very tight proximal LAD disease. So what happened is, during chest pain, for example, here, the patient have that sudden 100% occlusion of that proximal LAD. However, because we do ECG very, very quickly, we didn't quite catch the time when the ST goes up. However, as you know, inside the coronary artery is very dynamic. So sometimes the clot can actually dissolve by itself. So what happened if, let's say, you have a clot that dissolves by itself? So what happened is you have this reperfusion wave. So this reperfusion T wave in lead V2 and V3. So this is called what we call a Wellens wave. What is this very important? This is very important because it tells you that even though the 100% occlusion is no longer there, the patient have still very tight proximal LAD disease. So it's not time for you to relax. This is an emergency. You need to send the patient to the cath lab. So I repeat, in this kind of cases, the patient have a very tight proximal left anterior descending artery disease. When they have the chest pain here, they have a 100% occlusion of that LAD. However, fortunately for the patient, the occlusion actually dissolved by itself. So therefore, you see this reperfusion T wave called a Wellens wave. Okay, so this means that the patient have proximal LAD disease tight. So you have the patient, send the patient for urgent coronary angiogram, even if the patient does not have chest pain. So this is actually a very obvious example of a Wellens T wave.
I ask you a question at this point of time. Okay,
Sure.
so let's say this diagnosis was made in a center that in a hospital that has no cath lab facility.
Yep.
Okay, and looking at this, they would actually treat it as non-ST elevation MI most
Yep.
times, I would say.
Yep.
Would you then advise these patients to be thrombolized?
No. So because the thrombolysis, the reason we do thrombolysis is for acute 100% occlusion.
Yes, right.
So when the patient present like this, meaning that the flow has come back, you still have that tight LAD disease, but the flow has come back. So you don't have the 100% clot there. So I agree. If let's say you are in the outside where you don't have PCI capability, what you do is you treat like non-STEMI. So you give the dual antiplatelet, you give the subcut anticoagulation, because you wanted to pray, hopefully, that the clot doesn't happen again, and hopefully you can transfer the patient to the PCI able hospital. Otherwise, you just need to treat them as non-STEMI because there is no other option. If they would then develop ST elevation, then of course you thrombolize them. Otherwise, you don't thrombolize this kind of patient. So the patient again developed chest pain. So what would you do next? So obviously, you need to do coronary angiogram in a PCI-able situation. So if you look at this patient, okay, so this patient, you can see that, very little flow down the left anterior descending artery. So it's a very tight proximal LAD disease there and a very little flow down the LAD. So that's why the patient have that reperfusion T wave, okay? So that doesn't mean, patient have no chest pain, you can just not do anything. So obviously we open, the left anterior descending artery. So we open it, okay. So obviously the patient get better. So I just wanted, and after this, I will show you a very subtle case of a Wellens T wave that if you don't recognize the ECG, you wouldn't get the diagnosis. So what is Wellens criteria? So in order for you to diagnose it, it must be in the correct situation. Okay, you cannot just someone that is totally normal come to you to clinic for outpatient and then you see a biphasic T wave and say, oh, this is Wellens syndrome. But that's not how the way it goes. Okay, so the patient must have some symptoms. Okay, so usually they present with chest pain, and then after that when they come to see you, the chest pain has got better. So that is when the Wellens T waves happen because of the reperfusion. So you have a complete resolution of pain at the time of the Wellens, presence of normal R wave in the precordial leads, meaning that the ECG, the R wave is preserved. Remember, left ventricular hypertrophy is something that is very confusing. So very difficult to diagnose ST elevation or ST depression in LVH because that can be normal in presence of LVH. So the pattern can evolve or they cannot. They also possible that it doesn't evolve. So it can go both ways. The Wellens can evolve and become normalized, or it can stay that way. So this same patient with anterior Wellens syndrome, okay, then when you look and we listen to the heart, so the patient developed pansystolic murmur. Okay, so what would you do in patient with developed pansystolic murmur? So you need to check the heart. What is the reason the patient have pansystolic murmur? So you might ask yourself question now, how come Dr. Aslannif patient all have complication? Okay, so obviously I choose a nice case for you, okay, with a lot of picture, and not all the patient will present like this. Okay, this is a rare situation. So this patient developed a pansystolic murmur. So this is the echocardiogram. You can see that apical four-chamber view here. So left atrium, left ventricle, and right ventricle. So real case. So my CVT do the echocardiogram, okay, and then tell me, okay, there is a murmur, but I cannot see anything. So what I do is, okay, always find what is the source. So we just tilt and echo a little bit, okay. You can see that at the edge of the apical window, you can see that ventricular septal rupture there. Important for you to find out and tilt your probe to find a funny view to find your defect. So this patient have apical ventricular septal rupture. So our first patient have pseudoaneurysm. This is a patient with ventricular septal rupture post myocardial infarction. Also a cardiovascular emergency. So this patient also need to go for surgery.
I want to ask another question here.
Sure.
Okay, first, this Wellens myocardial infarction, it is very short-lived, right? Because the patient actually revascularized spontaneously.
Quickly. Yep, correct.
Yes. So is there muscle death in actual fact?
Must be, because they developed this ventricular septal rupture. There must be some weak somewhere. Yeah, and then after that, we don't know. We don't really know because of the tight proximal LAD. This might not be the first time it happens. Maybe in 6 hours prior, he had this attack again. Before his presentation, maybe he's got the blockage again that he didn't come and present in hospital. I don't know. This kind of funny things can happen. What we usually think is for ventricular septal rupture is, you treat late, therefore you have ventricular septal rupture. This situation is a little bit different. But it is important to remember that these incidents, such as ventricular septal rupture, such as pseudoaneurysm, has come down significantly because of a quick treatment that we do. So I just wanted to show.
I've seen a VSD recently with another.
Yep.
But I've never seen a pseudoaneurysm before.
Right. So
it's very interesting.
Yep. So this is a ventricular septal rupture there. All right. So, it occurs in about 1% of patients, but it's occur much less now because of primary PCI. Okay. So this is what I told you. I told all of them that anterior VSR is tend to be located distally. So our patient with anterior VSR, but inferior VSR can be complex. So I have a image of that as well. I don't want to show you, because once I start showing echo, I couldn't stop. Okay, so then it will be forever.
I want to see.
Okay. So now this is the image that I told you that is quite interesting. This is the patient of mine. Okay, so in IJN, so this is an Indian lady. Okay, he had history of PCI to LAD. All right. Now he had severe chest pain. Okay, so it come to the emergency department. So when she come to the emergency department, we look at the prior ECG. So she is IJN patient, and you look at this is the ECG prior. Okay, I just wanted to tell you, even though it is small, that the ECG is normal. Now, when I see the patient have already no longer having chest pain. Okay, the patient no longer having chest pain. So this is the ECG when the patient no longer having chest pain. Okay, so you look at the ECG number 1 and look at ECG number 2. Now, looking at this ECG, I already know that this patient is in danger. Okay, there is something wrong with this patient. Okay, so I actually asked the patient, okay, can we go, let's go to have a angioplasty because there's something wrong here. Okay, but because the patient does not have chest pain, the patient refused. Okay, say they don't want to have, because just recently have angioplasty. Why do she need to go for PCI again? Because she doesn't have any chest pain. So I try to, ask her, beg her, cry, do everything that I can, touch her, touch her feet, but still she doesn't want to go for angiogram. Okay, fine. Then I repeat another ECG. Okay, now I even more worried now. Okay, so this is the first ECG, no chest pain. The second ECG, no chest pain. I even more worried now. Okay. So now I even, I asked my friend to bet her. I asked the family member. I asked the grandfather, grandmother, daughter, grandchildren, all to ask. She still do not want to go for PCI. Okay. Because she doesn't have chest pain. Now I repeat the ECG. The ECG has normalized. Now she have developed chest pain. Now pain score is 10/10. Okay. So now she begged me to go for angiogram. Now I refuse. Okay. Now I said
Nah,
no.
don't
How
lie.
come? How come you don't want to go for PCI when I beg you? Okay. No. Okay. So like looking at this 4 ECG, right? Looking at the 4
Okay.
ECG, what do you think things that make me worry here? Why am I so certain that something is wrong here and something
Is
is wrong here?
is it the
Okay.
V2 and V3?
Yes, like you can look at V2 and V3. This is the initial ECG. You can see that a very subtle T
ST.
inversion at the end at V2 there. Very subtle T inversion at V3 there. Okay, so I know that this patient have been stented or the proximal LAD. So what is this? This is when the chest pain is better. You can see a biphasic T wave. It goes up and goes down, goes up and goes down. So this is actually a Wellens wave. So this is Wellens, exactly the same as our previous one, but the previous patient is not as subtle as this. Why is this changes subtle? Remember, whenever you want to address an ECG, always address it in comparison to the size of QRS. The smaller the size of QRS, the smaller the changes elsewhere. So you can see a biphasic T wave here that is very subtle. I know here that the patient already have Wellens. Okay, so that's why I asked the patient for go for angiogram. When you repeat the ECG, you can see in lead V2 and V3, there is a deepening of T inversion on lead V2 and V3. There's deepening of T inversion there. So things is getting worse. Okay, so I know this is Wellens. So I asked the patient to go for angiogram. The patient do not want because there is no chest pain because there is still flow. Now suddenly the patient developed chest pain 10/10. And we look at V2 and V3, we said, okay, now there is ST elevation is normal. There is no ST elevation. Why? Because this is what we call a pseudo-normalization. So the patient now have developed 100% occlusion. The ST is actually on the way to go up. We just catch it at the time when it hasn't gone up yet. So this is not normal. This is just a pseudo-normalization of the case. So we actually send the patient for PCI, and the patient have in total occlusion of the proximal LAD. So the stent got thrombosis 100%. So this is another subtle cases of Wellens. So just I wanted to tell you that, if your mind doesn't think of this kind of diagnosis, if you don't be careful on your ECG, you might miss this, okay? So our next case is a 50-year-old lady that complained of chest pain at home and collapsed in the emergency department. CPR was commenced, able to attain ROS. So ROS is return of spontaneous circulation, but the BP is extremely low. Okay, the echocardiogram was performed. Okay, so this is the echo. So this is another diagnosis. So what do you think the patient have? All right. So
Rupture
what is
free wall.
abnormal here?
Okay.
Yes, you can see this is the left atrium, right atrium, left ventricle, right ventricle. You can see a pericardial effusion there. Okay, not just any pericardial effusion. You also can see a coagula here. So this is actually a blood clot. You see that? That is a blood clot there. So that is also a blood clot. You can see this in a subcostal view. The blood clot is moving inside the pericardial cavity. So what is this? So this is actually left ventricular free wall rupture. Someone come to you in extremis or with myocardial infarction, and you do the echo and you see a pericardial effusion with blood inside the pericardial space, that is a left ventricular free wall rupture until proven otherwise. Okay, the only way this patient can survive if, let's say, the patient go and undergo urgent surgery. Okay, so this patient does not survive, but I just wanted to show you an example of left ventricular free wall rupture.
I need to
Like
ask a
very
question at this point of
sure,
time. Okay, now this is a free wall rupture. The patient needs to go for urgent surgery.
right?
Okay,
Correct.
and we have not reperfused the possibly an LAD lesion.
Correct. Correct.
Do we do both during the surgery?
Usually what they do in this kind of situation is, I mean, if let's say you can stabilize the patient, I think they will do both. They will, bypass the
Bypass,
whatever
right?
coronary artery that is blocked, yes, and then they correct the free wall rupture. The other way, if the patient is stable, but I've never seen that. Some people will do coronary angiogram first and
I cannot imagine.
demonstrate.
Yeah.
Yes, exactly, and demonstrate the occlusion, and then only go for surgery. But I see one patient in Mayo that survived this condition. I have the video and everything, but I don't have it in the presentation. Maybe in later time I can show you.
Yeah, maybe another time. Very,
So
very
this is a
interesting.
free wall rupture. So this is the most common, other than LV failure, but least recognized complication. Why? Because the patient is usually dead before they come to your emergency department. Okay, so I have shown you pseudoaneurysm, I've shown you ventricular septal rupture, I've shown you free wall rupture, and also I've shown you few ECGs that you need to remember. This is another case. So this is a 50 years old woman, post-anterior myocardial infarction, and was admitted to CCU after primary PCI to the left anterior descending artery. So unfortunately, the BP is persistently low despite additional inotropic agent. Okay, so this is the parasternal long axis echocardiogram of the patient. All right. Okay, this is the parasternal long axis view. All right. All right, and this is something that you see across that parasternal long axis view. So no, this is actually your tricuspid regurgitation for the patient. Okay, fine. All right. So this is MOD across that parasternal long axis view. Okay, so what is happening to this patient, do you think? So a patient that have acute anterior myocardial infarction, okay, you have revascularized the patient. However, the patient blood pressure is persistently low. The higher you put the inotropes, the lower the blood pressure. So what is happening here? So this is a complication that is well recognized, but well recognized in the literature. It happens, but rarely recognized in day-to-day practice. Okay, so this is dynamic left ventricular outflow tract obstruction, post-anterior myocardial infarction. So what happened? So what happened when you have anterior myocardial infarction is your apex become akinetic or hypokinetic. The basal segment overcompensate by contracting rigorously. So when the basal segment contracting rigorously, the anterior leaflet of the mitral valve will touch the septum during systole, mimicking exactly the same thing that happened in patients with hypertrophic obstructive cardiomyopathy. So this is actually a patient that developed systolic anterior motion of the mitral valve post anterior myocardial infarction. So a lot of people mistakenly think that SAM can only happen in HOCM. It also happen in apical myocardial infarction. It can also happen in Takotsubo cardiomyopathy. It also can happen in someone with hypertension with thick wall. So it is not just in HOCM. So you
There
can
are a
see
lot of
here.
MR there.
Yeah, there is also MR there because of the SAM. So you have an obstruction and also SAM. Yes. So you can see this is
how do we differentiate this from a papillary muscle
so
rupture?
now papillary muscle rupture, if you do your echo properly, you can actually see the papillary muscle head fluttering inside the left atrium. Okay, I don't think I have it in this presentation, but I do have it in other presentation where you can actually see the papillary muscle go up and go down. So don't put the color first. Do an echocardiogram and you see thing going in and out. Even a partial papillary muscle rupture, you can also see it go up and down. That's one. Number two, if you notice in this echo, okay, the MR occur exactly at the same time as a turbulent flow going into the left ventricular outflow tract. Okay, you can see this look like a V shape here.
Yes.
So when you do an MOD, you can see the anterior mitral valve leaflet, and you can see the anterior mitral valve leaflet go to the interventricular septum, SAM. Anterior mitral valve leaflet open in diastole and then go to interventricular septum during here. So the longer the contact between the leaflet and the septum, the more severe the obstruction. Okay. Now, same as HOCM. So what make HOCM worse? What make obstruction worse? So remember in HOCM, I give you a tips. Anything that reduce the afterload and reduce the preload is bad for the obstruction. So whatever you reduce the afterload and reduce the preload, the obstruction will get worse. So what is the thing that can cause obstruction to get worse? Number one, if you give inotrope. If you give inotrope, the LV will contract more vigorously. You will think that that is a good thing. No, because the LV contract more vigorously, you increase the time for the contact between the anterior microvalve leaflet and the septum. Therefore, you will make the obstruction worse. So one of the things that might tip you towards this diagnosis is this. Your patient develop low blood pressure post-MI, so you give inotrope, the BP go down. You give some more inotrope, the BP go down. Okay, so there's something wrong here. Do echo. Suspect systolic anterior motion is happening. Okay, so don't give this patient more inotrope. Okay, try to cut down the inotrope in fact. So that's number one. Number two, what you do, you give the patient IV fluid. Make sure the patient doesn't develop failure, of course, because the patient does develop myocardial infarction, but give IV fluid judiciously. So what IV fluid do, it will increase the preload, increase the left ventricular cavity, and reduce the contact between the anterior microvalve leaflet and the septum. You can also give low dose beta blocker, also to reduce the preload, increase the preload, sorry, not reduce. Okay, so anything that is increased is good, anything that is reduced is not good. If let's say still cannot, you can give a pure vasopressor to cause increase in afterload. Okay, so don't give inotrope, don't insert an IBP because IBP will reduce the afterload. So I have an example of case that we have here of someone that have SAM, that have low BP, then we give fluid, we can actually see the SAM resolve. Okay, so this is actually systolic anterior motion post anterior myocardial infarction. So in what setting this can happen? So MI, it is exacerbated by inotropic agent and IVP. So how to treat? You fill the ventricle. So you either give beta blockers and IV drips, you stop the inotrope, okay? You can squeeze the pre-free by give a pure vasopressor, okay?
Now, wait, hold on. What's the prognosis of this LVOT obstruction in
very good.
AMI?
Very good.
Yeah, because you there's no physical, I mean, no tear, no VSD.
Exactly. Yeah.
It's just a physical thing that will eventually come support, right?
Yep. So you were given a choice, like, what kind of complication that you want, and you have to have one complication, then you want to have SAM, rather than the other complication.
Okay, thank you. I will have SAM.
Okay, not you. So let's look at the other case. So we have a 36 years old doctor that developed sudden onset of chest pain. So the initial ECG is as follows, and he was given a thrombolysis. So this is the patient ECG. Okay. So what is this? Okay. So this look like a left bundle branch block, right? So I'm sure but I think a lot of people is aware now that you can diagnose ST elevation MI in the LBBB situation. So I'm sure you know and remember about a Scarbosa criteria to diagnose ST elevation MI in LBBB. Okay. So for those of you who are medical students or doctors who watch this, it is important for you to remember the difference between left bundle branch block and right bundle branch block. Okay, so even a senior doctor sometimes don't know how to remember a simple LBBB and RBBB. How to remember it? The only thing that I can tell you is remember it like a face. Okay, I cannot tell you that this characteristic or that characteristic. I just remember it. So you just remember how it looks like. The cardinal lead to look at bundle branch block is lead 1, lead V1 and V6. Usually lead 1 and V6 will be the same, and V1 is the clincher. So this is someone with left bundle branch block. Now, a cardiologist by the name of Elena Scarbosa come with a concept that is called appropriate discordant. Okay, in patient with left bundle branch block, the ST segment should go opposite to the QRS segment. Whenever QRS go up in LBBB, the ST must go down. Whenever the QRS go down in LBBB, the ST must go up. If let's say it goes the same way, then you got ST elevation myocardial infarction. In Scarbosa A, it is when the QRS go up and ST go up. In Scarbosa class B, it is when the QRS go down and the ST go down. You have another one that is called Scarbosa class C or Smith-Scarbosa criteria. That is when you have inappropriate discordant. Okay, you have to have discordant, but the discordant must not be too much. So I say this akin to a married couple. Okay, so a married couple that is divorced and they are still in talking term, that is left bundle branch block. Okay, they go the opposite way, but not too much. Okay, Now, a married couple that is divorced, but there is a lot of animus between the couple, okay? They hate each other's guts. So that is inappropriate discordant. So what do I mean? So if you look at lead V3 here, the QRS go down and the ST go up. That is normal for left bundle branch block. Okay, that should be okay. Look at lead V2, the QRS go down, but the ST go up. But look at the ST segment, it go up too much. Okay, this is inappropriate discordant. This is not a happy divorce. What do I mean by that? You measure your ST segment and you measure your QRS. If it's more than 25%, the discordant, then you have an inappropriate discordant. So that is scarbosa C. So all these are myocardial infarction. Now, I repeat again, scarbosa A when they go together upwards, scarbosa B when they go together downward, scarbosa C when they go the opposite way too much. Okay, that's all myocardial infarction. So in this patient, the patient do fulfill scarbosa C criteria and he was given thrombolysis. So this is scarbosa C, otherwise known as modified Smith-Scarbosa criteria. So in CCU, he become hypotensive and drowsy. Physical examination reveals a soft systolic murmur. So why is murmur in patient with MI soft? So the reason is because they have hypotensive. So therefore, the murmur is soft. So what is your next step? Obviously, always the next step is echocardiogram. So look at this. So this is parasternal long axis view. So what is this big thing here? The big thing here is pleural effusion. So this is a left-sided pleural effusion. This is a right-sided pleural effusion. That is the descending aorta. How do I know that this is not pericardial effusion? You can see that there is no tail here. Okay, if there is tail here, then that is a pericardial effusion. Okay, so why do the patient have pansystolic murmur? Look at this. What happened to the anterior mitral valve leaflet? Okay, you can see thing fluttering into the left atrium and going out of the left atrium. You see that? Thing going into the left atrium and going out. So this is the head of papillary muscle. So this is a papillary muscle rupture. And you can see there is a torrential mitral regurgitation. You see that? The mitral regurgitation go all the way, swirling inside the left atrium all the way back, otherwise known as Coanda effect. So this is someone with papillary muscle rupture post-myocardial infarction. And I think I have a 3D view. You look at the 3D view. So this is the anterior mitral valve leaflet. That is the posterior mitral valve leaflet. And look at that. See the papillary muscle going in and out. You see that? Dang, dang, dang. There's no music when you do the echo. Okay, that's just my mouth, but that's it. Okay. So this is acute papillary muscle rupture post-myocardial infarction. Right? So this patient need to go for surgery.
So the pleural effusion is actually part of the failure?
Yes, it is part of the failure.
Heart
So
failure.
this is the least, yeah, this is the least common mechanical complication. It can be either complete or partial rupture, but you can see this. Posteromedial papillary muscle most often involved due to single supply. Remember that the papillary muscle give chordae tendineae to both anterior and posterior mitral valve leaflet. The posteromedial give chordae tendineae to the medial side. The anterolateral give chordae tendineae to the lateral side. Often occurs surprisingly with relatively small infarct, usually the PD branch of the RCA. So this I think is our last case, I think. So this is 72 years old man with history of previous anterior myocardial infarction come for routine follow-up. Okay, so I just wanted to show you this because what is this? So this I just wanted to differentiate aneurysm with pseudoaneurysm. So this are the apical aneurysm here. Okay, so in aneurysm, all the wall is relatively intact. So the wall of the myocardium is intact, it's only thin. And you can see that the neck of the aneurysm is actually white. Okay, so this is example of LV aneurysm. So this is the difference between LV aneurysm and pseudoaneurysm. I've talked to you and I showed to you picture. All right, and in terms of RV myocardial infarction, so don't forget RV myocardial infarction, it occurs in conjunction with right coronary artery. If you have a distal right coronary artery, usually it involves only left ventricle. If it involves the posterior descending artery branch of the RCA, then you start involve the septal wall of the right ventricle or also the inferior wall of the right ventricle. If you go more proximal, proximal to the acute marginal branch, then you will involve the whole of your right ventricle. Okay, so that is right ventricular myocardial infarction. I just go to this quickly. So this is an 80 years old man with ischemic cardiomyopathy. All right. So this is that's something that we published in the American Society of Echocardiogram. Okay. This is a rare complication of myocardial infarction. So what is this? So this is intramyocardial dissecting hematoma. Okay. This is just like intramural hematoma in the aorta, but happen inside the ventricle. So you can see a blood clot here. This is actually the endocardium. That is the apicardia, yeah, and you can have clot here. You can look at this. This is intramyocardial dissecting hematoma. So what we can do in this patient is we can either go conservatively. All three patients that we publish, actually we manage conservatively. You know, we don't give anticoagulation. We just leave it until the clot become organized. So I think I just skip this. Okay, this is my last slides. So what is my take-home points? Okay, so knowledge of the ECG is important. So Amal Matu is one of the emergency physician that I follows, say that ECG is just an ink and paper. If in doubt, repeat. Okay, beware of the different level of urgency in going to the cath lab. Be familiar with Wellens, De Winters, STEMI equivalent, etc. Remember your echocardiogram. After ECG, this is the important tool that you have. If you have post-myocardial infarction, murmur, please look hard. Invariably, there is something lurking somewhere. If the BP get worse with inotrope, think about dynamic LVOT obstruction. It might be better just to take it off. So thank you very much. I just wanted to finish my talk with this quote that I love. The key to being happy is not the search of meaning. It's to keep yourself busy with unimportant nonsense and eventually you'll be dead. Thank you very much.
Thank you so much. I learned a lot, to be honest.
Thank you.
It was very, very interesting to me and very like a refresher course after so many years out of the academia. So we will take some questions if you have time. Is it okay?
Yep,
Yes.
fine.
So anyone with questions? So we have this Hazik said, how much is much? I think he's talking about your left bundle branch block, where you said that the ST elevation is more than the okay. How much is much? I think you mentioned 35%, right?
Yeah, so it's 25%. So this is Carbosa C. So the QRS should go opposite way to the ST segment. But if you measure the ST elevation, so you measure how many millimeter the ST elevation. So that is your numerator and the QRS is your denominator. So if it's more than 25%, then it is significant.
Okay, PC own said, I want to ask regarding the first case, is the ECG repeated after 12 hours done while the patient is having chest pain or pain-free? I can't remember what is the first case actually.
They have the pain-free. When the patient is pain-free. I think this is, if I'm not mistaken, it is the Wellens syndrome one. I think that is when the patient is pain-free and the patient developed T inversion, Wellens.
No, your first case is not Wellens.
It is not Wellens?
No, the first, I think your Wellens was third case.
Okay, so let's see what is the first case. I don't remember. Okay. Oh, yeah. Okay. Right. Okay. So what is the question again? I think this is the first case.
The first case is the ECG was repeated
2 hours apart. Okay.
So the second one, was it done while the patient was having chest pain or pain-free?
The patient is having chest pain, but not very significant. That's why they didn't send this patient to the cath lab.
So why do you repeat after 2 hours only?
Sometimes they do this. You know, sometimes what I do is whenever I see the patient in the emergency department, I ask them to repeat the ECG. So sometimes this kind of situation happen like this. So let's say you are someone who's on call, and then the doctor in the emergency department call you. Okay, say, Dr. Aslannif, I got someone here that no longer having chest pain. I look at the ECG. ECG is okay. Then they say, okay, all right, I'll come and see the patient. Can you just repeat the ECG before I come down? So
I see. Okay.
You come down and the patient repeat the ECG, you know. So I think this is too late. I think the real time to repeat ECG is 15 minutes or 30 minutes, not 2 hours like this. Okay. If you do 2 hours, it's too long.
Work is the work can be demanding when you're on call. But I think the guideline says that if you are in doubt, repeat the ECG in 10 minutes.
Yep.
Yeah.
Yep. You're right.
So somebody asked, May I know how IABP worsen LVOT obstruction? I think
So
it has got to do with the
yeah, this is Chai Yan Sun. Okay, so what IABP do is they actually reduce the afterload. Okay, so remember the LV need to pump against certain pressure inside your aorta, inflate your blood vessel. Okay, so the less pressure that you have to pump against, the more worse the obstruction. So when you give IABP, the afterload come down, then the obstruction will get worse. So that's the only way that I can tell you. Remember that in patient with
yes.
dynamic LVOT obstruction, any increase in afterload and increase in preload is good. Any reduction on preload and reduction on afterload is not good.
Okay. Anit Ayuni asked, any role of pericardiosynthesis if the patient developed LV rupture? I think you will just worsen the whole situation.
Yeah, usually you don't do it because really, I mean, it's very straightforward actually. Patient is very bad. You do pericardial effusion and you can see clot inside that pericardial effusion. So that is free wall rupture until proven otherwise. Okay, so usually we don't do pericardiosynthesis in this point. So my advice is don't do it. Okay, so just don't do it basically.
Yes, please don't do it. Firstly,
Yeah,
because you don't want to dislodge the clot. The clot is actually formed to seal. Okay, it's like
yeah,
our pathophysiology trying to seal the free wall rupture. Okay, and
yep,
then once you actually do the pericardial tapping or pericardial synthesis, you actually then reduce the pressure on the other side, and then all will come.
yep. You're
Uh,
right.
yeah. So I Najiha asked,
Hmm.
want to ask is there any specific management for the winters or Wellens that are different from
Okay.
PCS management?
Now, the winters is, if you recognize the winters, that is a STEMI equivalent. It is equivalent of ST elevation myocardial infarction. So you treat that as STEMI. If they say you are in a place that have PCI capability, it is primary PCI. Now, in a place that does not have PCI capabilities, please ask your supervising physician, because in terms of guideline, the guideline haven't said that you thrombolize in this situation. If I am the supervising physician, I will ask you to thrombolize, but this might be different to the other one. So don't take my word as advice in these winters. However, you just have to recognize how danger is the situation, how dangerous is the situation. Okay. Now, in terms of Wellens, if you have PCI, this patient need to go to PCI able. If you don't have PCI, you treat it like you treat other non-ST elevation myocardial infarction in terms of medication. But obviously, you monitor patient closely, because you know at any time the patient can develop 100% occlusion and develop ST elevation myocardial infarction.
WJ asked, can I know how do we diagnose ST elevation in a patient with right bundle branch block instead of the
Easy.
left branch? Easy.
Easy. RBBB, you should not have ST elevation in RBBB. There is no such thing as normal ST elevation in RBBB. Now, in LBBB, you can have normal ST elevation. In RBBB, no. So, any ST elevation in RBBB, in a correct context, it is STEMI.
And always remember to ask for any previous ECG. It is always very,
Exactly.
very helpful. Okay,
Yep.
it's if it's not a new patient to your hospital or your setup, it's very, very helpful to have an ECG actually
Correct.
compare, even if it left bundle branch. Okay,
Yes.
I think it was a very, very good session. I'm so happy and I'm so enlightened that I need to ask you to give us another session.
Thank you. Thank
So
you. I
I
will
will,
do. Thank you very much.
yes, I will speak to you privately, and then we will discuss. So,
Thank you so much for inviting
so
me.
I really, really enjoy these sessions. Maybe because I have more interest in cardiology, but
Yep. Yep.
really, really. Okay, so okay, join us next week. I can't even remember what we have next week now. Anyway, I will set up. Uh, yeah, I'll set up uh message for all and tell you what is happening next week.
Sure.
And with that, I thank you a lot, Aslannif, and say hi to
Thank
your
you. Thank
wife
you.
and stay
Yep. I will
safe.
do.
And
Thank you.
I will hope to catch you for another session next
Sure. just
Okay.
you know, just message me. Thank you.
Yes. Oh, I'm
Bye.
so happy. I really love it so much.
Thank
Thank
you.
you.
Thank you. Bye
Bye.
bye.
See you guys.